Great. So welcome, everyone, to our webinar today. Thank you for listening in on a Friday afternoon. The topic of our Preconception Infant Mortality CoIIN webinar today is New Approaches to Patient-Centered Reproductive Goals Assessment. I'm really excited to have Dr. Sonya Borrero as our speaker today. We just wanted to make sure that you knew that the webinar is being recorded. We will be archiving this webinar on beforeandbeyond.org under the Preconception Infant Mortality tab. We'll let you know when this recording is available, and we're also hoping that you'll provide feedback to us about today's webinar at the link provided at the end of our time together. As a reminder about what our Preconception CoIIN project is aiming to achieve, so our goal is that we will develop and implement and disseminate a woman-centered, clinician-engaged, community-involved approach to the Well Woman visit to improve the preconception health status of women of reproductive age, with a particular focus on low-income women and women of color. So with that, we're going to go and let me take a minute to introduce our speaker today. So Dr. Borrero is an Associate Professor of Medicine, Clinical and Translational Science, and Obstetrics, Gynecology, and Reproductive Sciences, all at the University of Pittsburgh School of Medicine. She also directs the Center for Women's Health Research and Promotion and is Associate Director of the VA Center for Health Equity Research and Promotion. She's an internist with advanced training in women's health and currently practices primary care in the VA Pittsburgh Women's Health Clinic. Dr. Borrero's work strives to advance reproductive health equity, which is really important for our CoIIN work, and I know for all of us listening in today. She also currently serves as board secretary for the Society of Family Planning. She's an appointed member of the Pennsylvania Governor's Advisory Council for Veteran Services and was recently appointed to be on the Pennsylvania Department of Health's Maternal Mortality Review Committee. And we are so excited that she made time in her busy schedule to talk with us today about this really important topic. And so I think with that, Sonya, I am going to turn it over to you.
Okay, great. Thanks, Sarah. And for all the participants who just joined, I told Sarah that if there's any clarifying questions or if you want to interrupt me while I'm speaking, that's totally fine. I don't think that this will take the full hour, so really up for some robust conversation. Let's make sure my slides are moving. Okay.
There we go.
So no disclosures. So as most of you know, about half of all pregnancies in the U.S. each year are reported as unintended. So you can see in green, 45% of pregnancies annually are considered either unwanted or mistimed. And unwanted has been defined as not wanting any future children at the time that conception occurred, and mistimed really means that the pregnancy was reported as occurring sooner than desired. And this unintended pregnancy statistic drives a lot of what we do in research, clinical practice, and policy. But why do we care? I think first and foremost is the assumption that unintended pregnancies are viewed as uniformly negative events by the women who have them. And then secondly, and perhaps more importantly, especially in the health domain, unintended pregnancy has been linked with a range of adverse health and social consequences. In particular, unintended pregnancy has been associated with inadequate or delayed entry into prenatal care, higher prevalence of smoking and alcohol use during pregnancy, a higher likelihood of depression and intimate partner violence, and infants who are born as the result of an unintended pregnancy have a lower likelihood of being breastfed and have higher incidence of poor perinatal outcomes, including low birth weight and preterm birth. So the logic model has been, in order to reduce all of these negative outcomes, all pregnancies should be intended and well-timed. And in fact, the Institute, and sorry, there's a little bit of funkiness on these slides in the conversion from PowerPoint to this Adobe format, but in the landmark report by the Institute of Medicine in 1995, The Best Intentions, the committee urged that the nation adopt a new social norm. That is, all pregnancies should be intended. They should be consciously and clearly desired at the time of conception. And this actually speaks as much to planning for pregnancy as to avoiding unintended pregnancy. And then, as many of you know, every iteration of the Healthy People document has included increasing the proportion of pregnancies that are intended in it. So one strategy to achieve this public health goal in recent years has been this concept of reproductive life planning, and I'm sure all of you are familiar with it. So reproductive life planning has emerged as a strategy to help advance this idea of reproductive life planning. It was initially proposed by the CDC, and it's been endorsed by other organizations, including ACOG. And in this framework, providers are encouraged to engage with all patients with childbearing capacity at every visit to help them proactively identify their childbearing goals, including the timing and number of children, and then make a corresponding life plan. So although the data on the effect of reproductive life planning as an intervention is sparse, the hope is that these conversations will first reduce unintended pregnancy, and second, reduce adverse maternal and perinatal outcomes by helping women to address health issues prior to conception. So is this a realistic goal for all women? I think for many women, and we have preliminary data certainly to support this idea, but the concept of having and following a reproductive life plan can feel empowering, and it does resonate with some women. But it's not necessarily a relevant concept for all women. So I'm going to go through some recent qualitative studies that I think have led us to this realization. But basically, I think we're all coming to sort of, this place where we're realizing that women's own pregnancy perceptions and lived experiences may really make achieving the public health goal that all pregnancies are consciously desired and planned difficult. So first, and again, I'm going to go through in the next couple of slides some illustrations of these concepts, but a large proportion of women do not have clear or binary intentions. And in fact, this I think just got recent attention in the New York Times. Studies have shown that anywhere between 30 and 40% of women have or are ambivalent around their pregnancy goals. Second, women may not see pregnancy planning as desirable or achievable. And again, I'm going to dive into this a little bit more. And then as I think we all probably know, either intuitively or through experience or vicarious experience, unintended pregnancies can be happy, welcome events. Okay, so I want to share with you some data from recent qualitative work to just, again, dive into some of these ideas a little bit more. This is a study by Anu Gomez with young adults, I believe in California. And so this is sort of a portrait of ambivalence. So one woman said, sometimes I probably want to get pregnant when I'm 22 or 27, or probably soon. Who knows? Probably when my daughter starts walking, maybe. And another person said, I already have a kid, so I'm not opposed to having children. If it happens, it happens. I prefer we don't have children right now, but if it happens, okay. So the second sort of broad idea is this one that formulating intentions or plans may be viewed as irrelevant. So this comes from some qualitative work of mine a couple of years ago with low-income Black and white women in Pittsburgh. What we really began to understand is that many women actually feel that they have no reproductive agency around whether and when they'll get pregnant. And so these are some quotes that illustrate that concept. So if you're meant to have a kid, you're meant to have a kid. Why take something to prevent it? And second quote, nobody can really plan for a pregnancy. Like you could try, but a lot of people that want to get pregnant don't get pregnant. And then there's a lot of people that don't want to get pregnant and it just happens. So this concept of it just happens comes up time and time again across multiple studies. A separate but related concept is this idea that formulating plans may be viewed as unrealistic. So again, in my study, we asked women, and again, these are low-income women, what does it mean to you to plan a pregnancy? And of course, as a healthcare provider, I was kind of, expecting or hoping to hear some narratives around optimizing health. But what women talked about universally is achieving certain social norms. So, getting married, having your finances in order. Not one brought up optimizing health. And what became clear to us as we were talking to these women is that achieving those social norms was actually incredibly elusive in their lives. None of them, in fact, had achieved any of these social norms. And so what we learned, though they didn't explicitly state this, what we learned is that it seems that it is socially more acceptable to have an unintended or unplanned pregnancy than to explicitly plan one in non-normative circumstances. And of course, these social norms are based on sort of white middle-class norms that really were not realistic in the context of these women's structural realities. So I wanted to share, there's an excerpt from Catherine Eden's book, Promises I Can Keep. She did an ethnography with low-income men and women in South Philly and in Camden, New Jersey, and she found something, she found sort of the same concept, and so I just wanted to share this few sentences from her book. So the lack of a clear plan does not mean there is no desire to get pregnant, yet those who admit, even to themselves, that they're trying to have a baby invite public contempt and self-reproach, for they know that the choice to bear children while young and unmarried is in many ways absurd. At the same time, they wonder if their circumstances will ever be right. And then I wanted to share a quote from my my study that I think just illuminates the type of judgment that women sort of fear. So one woman said, she's talking about a friend of hers, they're engaged, but they decided to have this baby before they were going to get married. Like they were striving. She planned this baby. She started going to the doctors and taking prenatal pills before she got pregnant. Like she planned to have this baby. And I didn't know that part because I would have had an issue with that because they're not married. This just was so striking to me because this woman herself had had multiple, I think 3 pregnancies in non-marital context. But it's the idea of explicitly trying in a non-marital context that I think she found, irresponsible. And then I think we all know that unintended may still be welcome. So these are quotes from a study by Abigail Aiken with Latinas. So one woman said, I don't want more kids than I was hoping to get my tubes tied. We can't afford another one. But if it happened, I'd still be happy. I'd be really excited. We'd rise to the occasion. Nothing would really change. And the second quote is really sort of building on this idea that, in fact, sometimes these unplanned or unintended pregnancies can really be a turning point towards a more positive trajectory in some women's lives and men's lives. So this woman said, honestly, although she wasn't at all planned, I think my baby girl saved me. When I think what I would be doing now if she had never come along. And we hear this as well. So I just want to take a minute. My work is primarily focused on family planning. And so I just wanted to throw this in here, which is to say that this sort of focus on reducing unintended pregnancy manifests, I think, in the clinical space as a LARC-first approach. That is, these are the methods that are most effective at reducing unintended pregnancy, so we should be promoting them. And I think this kind of clinical approach is really amplified by ACOG and the American Academy of Pediatrics when they sort of stated that LARC should be considered first-line options for all women and adolescents. They have, both organizations, I think, have stepped back from this first-line language. But I wanted to bring this up because I want to share the next few quotes from a study by Jenny Higgins with young adult college-age students, college students, also college age, but college students, which really speaks to the relationship of ambivalence to LARC use and brings up this idea that, in fact, LARC methods can be too good. So one woman said, the IUD takes the element of surprise out of when we would have our next kid, which I kind of want. I don't want to put too much thought and planning into when I have my next kid. And that's another, we saw that a lot. That in our study in particular, many women really felt that they did not want to have such a constrained approach to pregnancy. This sort of, following a strict planning paradigm, that they wanted to just let it happen. And then this is my favorite quote. IUDs and implants really take away the element of surprise of having babies, which some people want and some people really, really don't want. You can accidentally forget the pill and get pregnant, but an IUD is not going to pop out and take a jog around the block. Okay. So I think, this work, and for me, my work in particular, really began to sort of illuminate for me this possible tension in a public health perspective in which unintended pregnancy is sort of unequivocally a problem to be solved, and this more person-centered perspective in which not all unintended pregnancies are created equal. Certainly, they may be catastrophic for some folks, but they may be happy, welcome events for others. And so, in the beginning, I kind of talked about why we have this public health goal. It really rests on this assumption that unintended pregnancies are, a monolithic and negative event. And I think, the quotes and the qualitative work we've done has really sort of debunked that idea. But the second kind of pillar on which we rest our public health approach of reducing unintended pregnancies is this linkage between unintended pregnancy and adverse outcomes. And so I just want to talk about that for a minute, and I'm not going to get into too much detail. But I will say that studies assessing the relationship between unintended pregnancy and adverse outcomes are incredibly fraught with numerous measurement and analytical issues. And again, I can't get into all of these. But I'll just say, since, clearly pregnancy intention can't be randomized, so it's really hard to control for confounders. And truly, the circumstances that lead to unintended pregnancies are the same that lead to adverse maternal and infant outcomes. And we just can't sort of remove that. And so when we look at the studies assessing this relationship, with an eye towards the ability to sort of isolate, we find that, in fact, the association between the independent effect of unintended pregnancy and adverse outcomes is not as robust as we like to state. Another issue is that unintended pregnancies, as I said in the beginning, includes both unwanted and mistimed pregnancies, and most studies lump those together, but they may have very different effects. Even the severity of mistiming. For example, a mistimed birth that occurs, 10 years before you wanted it to is very different than one that occurred maybe 6 months before, was ideal for you. So this sort of shows the relationship between unintended pregnancy and adverse maternal behaviors and outcomes. And really the strongest associations are with delayed recognition of pregnancy and delayed initiation into prenatal care. And this second slide shows the relationship between unintended pregnancy and neonatal and infant outcomes. And again, with an eye towards really trying to isolate those studies that are the most robust, really the evidence seems to be strongest for reduced initiation of breastfeeding. So I think, there are a number of limitations to our current public health and, clinical paradigms that are very much focused on a strict planning framework. So first, I think that as we've hopefully, illustrated, it doesn't accommodate the full range of women's lived experiences and their conceptualizations of pregnancy and how they would like pregnancy to occur. Second, I think the framework really overstates the relationship and some, in fact, sort of suggests causality between unintended pregnancy and adverse health and social consequences. And I think the danger of doing this is that it often positions unintended pregnancy as the cause of all of these poor outcomes. And therefore, the solution to all sorts of social and health ills is simply preventing unintended pregnancy, often through LARC promotion, rather than really examining and addressing the underlying social and structural determinants, which, again, are complicated and hard. But I think are incredibly necessary. And so, through all of this work, it's become clear to me and many of my colleagues that the singular focus on unintended pregnancy, which, as a researcher, that has sort of been our main metric and benchmark for the last 2 decades. But the singular focus on this metric is a marker of reproductive autonomy, and the degree to which outcomes are optimized is totally insufficient. Related, and I think maybe perhaps especially important and relevant for all of you, is I worry that the need to express an explicit plan or intention to get pregnant to a healthcare provider may preclude the possibility of helping some women prepare for the possibility of pregnancy. And so sort of taken together, all this body of work has really led myself and my collaborators to question, how do we actually center efforts on truly supporting women's autonomy and well-being rather than simply trying to prevent unintended pregnancy? And unfortunately, I don't have a great answer, but I can tell you kind of what some of the things that we've been trying to do in the last couple of years. So again, sorry for the weird formatting on this. But one thing is I have really tried in my language to move away, and even in my thinking and my rationale for doing the work I do, I've been trying to move away from a reducing unintended pregnancy framework more towards a rights-based, justice-informed framework. And for this, I've really relied on sort of the global acceptance of a human rights, of the basic human right of individuals to decide freely if, when, and under what circumstances to have children. And fortunately for us, this was codified in the 1994 International Conference on Population and Development in Cairo. And so I feel like we should rest on this, right? It's established and it's globally accepted. It is inherently person-centered, which, as many of you know, is aligned with how we are trying to move in medicine. And then I think it is enhanced by the reproductive justice movement. And so I'm not going to talk too much about the reproductive justice movement, but I want to say that it has helped really interrogate and address the reasons for which the most marginalized populations and people are unable to fully realize this right. Okay, so I want to talk more about how this, sort of the application of this idea and this framework in assessing reproductive goals and in clinical care. But before I do that, I want to talk a little bit about the background of patient-centered care. And hopefully most of you know some of this, but the concept of patient-centered care really has gotten increasing attention since, again, the Institute of Medicine included it as one of its 6 domains of quality in the report, Crossing the Quality Chasm in 2001. And in that report, the IOM defined patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values, and it ensures that patient values guide all clinical decisions. And this focus on patient-centered care as a component of quality, I think, is driven by 2 main factors. So the first is, finally, the recognition that the traditional model of care, which was often focused on the physician or other healthcare providers, was really not well suited to meet the needs of the people who the healthcare system was designed to serve. And then another reason, the second reason that patient-centered care is a component of quality care, or at least that we can justify that it is a component of quality care, is that there's evidence, not surprisingly, that when we focus on the needs of patients, they do better with respect to health outcomes. So patient-centered care includes, multiple domains, including physical comfort and accessibility. But one of the central components of this construct is the value of interpersonal communication between healthcare providers and their patients. So fostering positive, respectful, therapeutic relationships helps ensure that patients can feel that they can express what their needs and preferences are. And it also helps to ensure that providers appropriately respond to these preferences with education and counseling that integrates both medical evidence and the individual patient's perspective. There is evidence in other healthcare domains, less so in family planning, although I will say Christine Dellendorf is really kind of leading the charge on collecting this data. But there is evidence that patient experience of interpersonal communication affects patient satisfaction, not surprisingly, use of preventive care, and medication adherence, which, I think contraception is sort of aligned with both preventive health care and medication adherence. Okay. So in thinking about how we wanted to apply some of these patient-centered principles to promote a patient-centered approach to reproductive goals counseling, we really wanted to make sure that we were drawing from the research that we and many of our collaborators have done. And I think first and foremost, we just wanted to make sure that we were engaging with the full diversity of women's thoughts and feelings around pregnancy, and that we are attentive to our own assumptions and biases about who should and shouldn't be reproducing. I mean, I learned so much in these qualitative interviews. And, there were things that just blew me away. This idea that planning, in fact, might not be attainable for some of our most marginalized populations. And so in order to do that, we wanted to make sure that we're using inclusive, non-judgmental questions to ask people, actually, what are your reproductive wishes, your goals, your intentions? I think it's also critical that we not only recognize that ambivalence may not be resolved, but that we are open about eliciting it and attending to it. And because ambivalence is normal and may not be resolved, and because planning may not be desirable or attainable for some women, I really moved away from planning language unless women indicate to me that they have a very planning orientation, which many of us do. And I've used more preparing language. So we talk about can we talk about ways to prepare for the possibility of a pregnancy? And then again, because ambivalence or indifference are common, and because some women prefer pregnancy to occur this way, efficacy is not always the most important characteristic driving contraceptive decisions. And again, as a family planning researcher, this was such an important take-home point for me, that in fact, LARC methods can be perceived as too good for some women. So I just want to share with you, this is a paper that we published in AJOG in 2017 that really lays out kind of our vision for patient-centered reproductive goals counseling. And basically we've redefined what reproductive, or not redefined, I don't know, but we've defined reproductive goals counseling and how we refer to it. And it starts with a reproductive goals assessment. And the next few slides are going to talk a little bit about what we've kind of envisioned or laid out. But depending on how women answer questions about what their reproductive goals, intentions, desires are, the next set of counseling strategies can include preconception counseling or contraceptive counseling, and often a blend of both, recognizing that women are not always very clear or binary in kind of their reproductive goals. Let me just talk about some of the very concrete tips that we offer and suggest. And this one seems obvious. Begin with a trusting personal relationship. But I have to say, I think we all assume that we are incredibly patient-centered and friendly in our clinical encounters. But Christine Dellendorf audio recorded, I think, about 400 clinical visits for family planning consultations, and found that only in 65% of visits did the provider greet the patient warmly and introduce themselves, and that small talk only happened in 45% of visits. And for decisions and counseling like reproductive goals and contraception and pregnancy, women seem to really desire this sort of intimate friend-like conversation. And then, I mentioned this before, but really making sure that our own biases and judgments of women's reproductive desires or goals does not influence counseling. And then asking open-ended, non-judgmental questions. And I'm sure all of you are familiar with one key question, so that's certainly one approach to asking women about what their pregnancy goals are. We've been using the path questions, and for me, I really like these because I think they're very explicit about allowing ambivalence to emerge. And second, as a primary care doctor, I like to have a sense longer than, so one key question, as you probably all know, is would you like to get pregnant in the next year? But this gives, the path questions have a much more open-ended kind of time frame, so it lets people decide what's most relevant for them in terms of timing. So our questions are, do you think you might like to have more children at some point, or children at some point? And if they say yes, do you have a sense of when that might be, or when do you think that might be? And then how important is it to you to prevent pregnancy until then? And again, this is sort of launching point to either having preconception, contraception, counseling, or both. And then yes, that's this third step, I guess, focus on individual values and patient and preferences. So we really recommend that reproductive goals counseling prioritize the relevant information according to women's values and preferences and needs. So for women with clear pregnancy intentions or desire and who have a planning orientation, creation of a reproductive life plan may be incredibly helpful and empowering. For those who are ambivalent or considering pregnancy in a more distant future, or for whom, planning does not feel as relevant, you can ask if you're interested in talking about ways to prepare for a healthy pregnancy or prepare for the possibility of pregnancy. And certainly motivational interviewing may be appropriate for women with modifiable preconception risk factors who desire pregnancy at some point in the future. So in summary, I think our current public health and clinical paradigm for reproduction has been heavily focused on pregnancy planning. We're increasingly realizing that pregnancy planning may not be a relevant or even attainable construct for many populations of women, for many women, especially I think our socially marginalized populations, and that we can come up with patient-centered strategies that really need to engage with the full range of women's thoughts and feelings around pregnancy. And I've outlined a couple of approaches we're taking. We're still in our infancy here. These are things that we've been, proposing and using in clinical settings, and we're hoping to test them more. But I do think that we need a much better understanding of how we can support diverse women in the context of their lives to optimize reproductive health while supporting their autonomy. So that's all I have, as promised, to take the full hour.
Thank you. That was great. I feel like if we weren't all on computers, you'd hear a lot of clapping. Because I think you summarized just a lot of really, really important points in a really succinct way. And so I see we've got someone typing in a question, but I have one while we're waiting for that one to show up. And so my question is, how have you actually made this happen in your practice? Was there any training that you and your team have done? Do you role play? Like how do you start to shift the way you approach this?
Well, that's a good question. I mean, I have to say it hasn't been systematic yet. I started adopting this approach. Do you know Patty Kaysen, Sarah?
I definitely know the name. Mm-hmm.
Patty Kaysen is really the ringleader behind all of this. She's a trainer and a nurse practitioner, and she came up to me after, I was presenting my research, I think it was back in 2013, 2014, and I was just presenting the research at one of the Title X clinics, and she came up to me afterwards, and I was sort of talking about all of our pitfalls of how we think about, that we have such a strict planning paradigm in our biomedical context, and it's just not accommodating women. And so she was like, what I've been using in my clinic are these, these 3 questions, and I just feel like it just resonates. And I really liked them, and I started just individually using them in my clinic. And then we kind of got a movement around them, and we codified them and published them. And now we've been really, we do a lot of training, especially, I just talked at NIFRA, and I talk at the Title X. But what we're hoping to do is test it. What we'd like to do, the trick is that, we're all on board. And so we're excited to jump into these questions. But I'm working now with a bunch of subspecialists who also are women's health champions, but trying to get their colleagues in rheumatology and pediatrics, all of whom often prescribe teratogenic medications. Is like pulling teeth, right? No one wants to have these conversations. This is really scary. And so we're trying to come up with a more systematic, like I said, way of doing this. We have been engaged through my center. So I run the Center for Women's Health Research and Innovation. We're just starting what we call a FemTech collaborative. And it's a bunch of patient-facing as well as provider-facing kind of complementary pieces to support reproductive goals, assessment, reproductive decision-making, and facilitate shared decision-making. So we want to test those, and we're busy writing grants right now. So stay tuned. I mean, like I said, I do it. It's worked really nicely in my clinical experience. My mentees use it. The people who work with me have been using it and kind of, I think, really appreciating it. One key question is, like I said, is easy. The beauty of one key question is its brevity, and people can remember it, and it doesn't feel as scary. Our questions really are, wanting to dive a little bit deeper. Tell me more about your
right.
There's just not a lot of robust evidence yet around any of these questions.
Right. Well, I think you make an interesting point about, well, first of all, we all need to be much better at this. But then also when we think about other specialists, and we think about women with chronic conditions or other ability differences, where, this idea of intention takes on a whole additional layer. In terms of expectations about, well, if you have diabetes, you shouldn't get pregnant, etc. And so when we don't have our specialists on board with this, I feel like that can make it really challenging to be able to support those women in their pregnancy goals in an authentic way. So I'm glad that you started the conversation with specialists, and I do think that that's an area for us all to think about future collaboration and how to make it easy for them. Yeah. Go ahead.
No, I was just going to say, it's very easy to be very non-directive with healthy patients, right? Like, whatever you want, I will support. It adds definitely a layer of nuance and challenge when we are seeing women, and one of my mentees is a rheumatologist, and the cases that she brings to me are just, they're mind-blowing, right? These are women who have never had conversations with any healthcare provider about not only how their disease can impact pregnancy, but how pregnancy impacts their health and well-being and their disease. And then, all of these women at some point or other are put on methotrexate, which is an abortifacient, and almost nobody talks to them about contraception or reproductive goals. And so it's just, it's just a whole nother level, when we think about women with really serious chronic medical conditions.
Right, and thinking about how does that fit in that justice lens is really important.
Yeah, and I really struggle with that. There's a lot of tension because I know, what we want to do is give space for women and an entree point to come to us as a medical community to talk about these things. But we also don't want to, there's been a lot of pushback in women's advocacy organizations and rightfully so in the justice community about over-medicalizing women's reproduction, right? And so finding that fine balance, I think, is kind of what I was trying to get at in that last bullet point on my summary statement. Like, how do we do this right and well?
Exactly. So a great question in the chat, which is how does comprehensive, medically accurate sex education and K through 12 education fit into this conversation? More to the point, I wonder if there might be changes in various groups of people's sense of control over their reproductive lives if health education in the United States was more robustly supported and available. And I think this is a great question. It mirrors a conversation our team had just on Tuesday and reflecting on some of the work that we've been doing and hearing some women even thinking that if they take so if they're not pregnant, they don't want to get pregnant, but they're taking a prenatal vitamin, that just the taking of a prenatal vitamin will increase the likelihood that they will get pregnant, and just really understanding that there's such a lack of even understanding our own reproductive systems and how fertility works. It's surprising how few people understand that. So what is your thought about what would it be like if your patients came to you with more knowledge about their bodies and contraception?
Yeah, this is such a huge area that I have no good answers for, and it's such a travesty to me how little education is occurring about. Yes, we all have had patients who you're just floored with how little they understand about their bodies, and through no fault of their own. Right now, actually, our team is developing a decision support tool for sterilization. That's a sort of a major body of work of mine, sort of understanding racial and ethnic differences in the use of sterilization in this country. And in our formative interviews, to understand what women want, their information decision needs, I mean, it came through over and over and over again. Like, we just don't even understand what's happening in our bodies. And so we thought this was going to be a decision aid that was completely based on deliberation components and intuitive components, right? Just making sure that their values were aligned with sterilization. And instead it's become very education heavy. I mean, we have a whole video on how pregnancy happens and what are the parts of your body. That just spoke to me how little information people have. And, again, I don't have a great solution. It's so sociopolitically driven, unfortunately, that
right.
I mean, there's people doing great work, and there
right.
are workarounds. We have, and Kelly Nessman, who's my administrator, I think, is on the call, but she's worked with, there's an educator here in Pittsburgh who has her own nonprofit who goes around doing sex education, sex positive, very frank, but it's only the private schools that can afford it. And in fact, we have our crisis pregnancy center networks do half of the sex education in our public schools here.
Mm-hmm.
So
well, I think, sorry. I mean, I think to your point, we can try to go to the schools and try to support in school nurses, school-based health clinics. I know in New Jersey, for example, they offer comprehensive contraceptive services in their high schools and now even in their middle schools. So, I think there are some models that we could hold up and consider. And then I think also it's important for us all to remember as we're going into counseling that, perhaps, what we might want to integrate into a well-woman visit or into resources available might be having information in the waiting room or in different places that can provide this important information to our patients. So if we know that they likely don't have it, being more proactive with the contact that we have with them to provide that to them. So I think this is, thank you for that comment. It's incredibly important. And so this is, go ahead.
Oh, I was going to just throw in one more thing that maybe you all have seen. So in our research, we've really found that a huge proportion of women have misperceptions around their fertility. And we can't quite figure out why this is the case. When we try to probe, it's often that women are like, well, I had sex unprotected once and I didn't get pregnant. And I think, sometimes when we talk about pregnancy, we say things like, oh, it only takes one time. And so I think we've sort of, and again, I'm totally speculating here, but I do think that, I wonder if we've perpetuated this idea that pregnancy happens so readily and easily that when women don't get pregnant with 1, 2, 3, anywhere up to 20 acts of unprotected sex, they begin to think they're not fertile. And so in one of our decision aids, we actually tackle some of this sort of perceptions of and it is really hard to communicate cumulative risk over time that's quite high of a relatively low risk single event activity, right? So we've been trying to tackle that too. But, our tools are really trying to do a lot more education, and, these are adult women at this point, but talking to them about fertility and menstrual cycles and how pregnancy works and what are your body parts and all of those things, so they can make an informed decision.
Yeah, it's a lot to be done in a short visit, but seems like an important investment for her and her well-being. Yeah. So Let's see, we have one other question maybe being typed. Oh, here we go. I work for a nonprofit organization that supports the top health officials in the U.S. states and territories. If there was one thing you would want to communicate to these folks, what would it be? Top health officials in the U.S. and territories.
Not reproductive health officials. Oh my gosh. Well, I mean, going back to this, I think really supporting women's ability to make informed and value concordant reproductive health decisions, I think it's just like of the utmost importance, not only for a healthy society, but, just our ethical mandate, and sort of speaks to the humanity of, our population, right? I mean, I know that not everyone wants to have children, but family formation for most people is sort of the core principle of life. And so doing what it takes to support that, whether it's, access to information, to contraceptive methods, to have healthy pregnancies and parent and safe environments, all of those things are really critical for a healthy society. And that does mean actually also addressing some of the, underlying social and structural inequalities that prevent and constrain people from having that freedom.
Right. Excellent. Thank you. That's a great question.
Well, that's hard. I'm sure think about it more and have another answer tomorrow. But.
That's awesome. Well, it's great because she's on it. That's fantastic. Thank you. No, this is, I think, a really helpful and important conversation for all of us to have, and we really appreciate the time that you have spent giving us this information, and hopefully we can stay connected. I wanted to call attention to the work that's happening also right now with the Black Mamas Matter Alliance and their collaborators. So we're really focusing on Black maternal health and wellness, and wanted to call attention to something that was published that really aligned with your presentation, Sonya. So Dr. Joya Career-Perry highlighted an op-ed titled "Contraception is Not a Remedy for Poverty," and so there's a link for those of you that are interested in checking that out, and clearly in alignment with some of the things you were talking about. So for those of you that aren't part of our CoIIN project and would like to join with us on social media and jump into the conversation, please do. We also do have our monthly newsletters for our CoIIN project, and we spend time on them, and so we would love to share them with you. We'll definitely be highlighting this webinar. So you can sign up through our website or email Suzanne W. And also, we would love your feedback to our webinar today. That would be great if you might be able to take some time to offer that. And I think with that, we can say thank you again for your time. Thank you, Sonya. Hope everyone has an excellent weekend. And we look forward to staying in contact with all of you and working together to think about how we can provide support these conversations in a more authentic and justice-centered way. So thank you so much, Sonya. I hope to talk to you soon. Thank you, everyone. Have a great day. Thanks, everyone. Bye.